All right. Red Nation, today we're going to be talking about contrast media and specifically how that impacts your CT scanning and the timing in order to get good images of contrast enhancement in the given organs that you're looking for in your CT scanning. Coming up here at How Radiology Works, here's just a quick image of the vascular system, specifically the arteries is shown here, just a pictorial. And a lot of times we're looking at images like this that we want to make. Here's an image of a peripheral runoff. Here's an image of the chest, namely the heart. Here's an image of the brain. In each of these images, you're able to see contrast in these images. And we're going to talk about the contrast timing, how we inject contrast, and how we can time it such that when we're looking at a given organ, we're able to make an image with relatively optimal contrast enhancement. You know your heart is consistently beating as long as you're healthy, and the right ventricle is pumping blood through the lungs, and then the left ventricle is pumping blood through the rest of your body. You can see here there's lots of details as far as the connections in the cardiovascular system. So these are all known things about a standard cardiovascular system, but we'd like to go to a simpler model even. So if you look at here, again, you can see we've got blood coming from the veins, through the heart, through the lungs, through the heart, through the aorta, and then through the body. We can think about simplifying this even further. If we look at an image like this, again, you know in reality that you have all those different chambers that we had on the first image. For the purpose of what we're doing in CT, we're actually going to inject contrast into the veins in CT. It's a lot easier than doing an intra-arterial injection from the perspective of establishing the IV, also from the perspective of the risk of infection for the patient. So we have our IV injection shown right here. Then we have our little yellow school bus shown here. That's going to trace us through the path that we're actually going to go through. We're actually following this white line here. So we're actually going to go from the point at which we inject in the veins, through the heart, through the lungs, back through the heart, back through the aorta. We do our contrast injection in the veins. And when there's a lot of contrast in the veins and in the superior vena cava, you can actually get artifacts. So here's an example of an image from a dual source scanner, but you get these kind of artifacts on basically any scanner. When you have very high contrast pooling, it gets similar to the case of metal artifacts where you can run into significant beam hardening, photon starvation. You can have motion of this contrast pooling as well. So this can cause significant streak artifacts. We're going to talk about some things we can do later to try and reduce these in practice. If you wanted to be imaging contrast in the lungs, you would want the school bus to stop here. If you're thinking about your standard liver, where you're going to have an early arterial phase, you would want to stop right here for your early arterial phase. This is where the contrast has entered the arteries. And if you go on, you would have a late arterial phase where the contrast has had some time to actually pass through all of the arteries within the liver. And then finally, you'll go to a portovenous phase wherein the contrast has actually started to go through the veins as well. Let's talk about what this contrast enhancement is going to look like as a function of time. On this axis here, we have the time. And on this axis here, we have the change in Hounsfield units in the aorta. So if we look at a region of interest in the aorta and we say, what's the enhancement or the change in the Hounsfield units from the background to the contrast enhancement? What we'll see is actually in this simplified model, there's a delay because the contrast is injected right here at time 0. And then like we talked about, it has to go veins, go through the heart, go through the lungs, and then through the aorta. So that is the time that we're going to talk about here. We call that time T arrival. So the T arrival right here is from when we do the injection till the contrast has arrived. And then if we look about when is the contrast going to start going down, it actually is the width of the contrast, or namely the length of time that you're injecting the contrast, plus the arrival time. So how long does it take to pass through? That is roughly the time at which the contrast is going to start going down. If you think about removing a couple of the simplifications from that model, so that's the simplest model where we're talking about a very short injection and also an injection that assumed basically the steady state parameters. But what actually happens is we actually change by the fact that we're actually pushing contrast into the body. That's actually changing the system. We're actually going to have the contrast coming down a little bit faster. You can also see here the contrast isn't returning quite to zero because there's actually contrast recirculating, having gone through the whole circulatory system more than once. If we think about our simplified model, one way to actually make a long injection is to make many short injections. So here is an example where we keep adding many short injections in order to build our long injection. So when we add all those short injections together, you can see the long injection looks something like this. You can see right here, the arrival time is actually going to be the same, but then the contrast is going to go up. And now we're looking at adding all these ones together. So over time, we get a plateau, which is going up some here rather than a relatively stationary plateau that goes down quickly, because all of these little components are getting added together. And then the same thing that we talked about for the short case, you can think about the duration that we injected plus the arrival time. That's approximately when it's going to start to go down. Just like we had in that short injection, there's actually going to be an effect of that contrast pushing through, and that's actually going to move the decay a little bit earlier. And we also have this recirculation effect right here so that the contrast doesn't go down to zero right away. We're actually going to talk about how we can scan this on your CT scanner. And there's actually a couple ways that you can do it. You can either use a test bolus where you send contrast in at the same flow rate, but you send a smaller volume right away, and then you make many images, and you can track over time how that contrast comes in. The other option is you can do tracking of the actual imaging bolus in a monitoring phase, and then you can prescribe essentially when you want to start your diagnostic phase along with an offset in time. And so we'll show you how that looks on this plot here. So we typically want to figure out when the contrast has arrived, and if we set a threshold for when there's enough contrast there, you don't want that threshold to be too low because it could be influenced by noise. And you don't want it to be too high because you might never get there. And then you're going to have real problems with your acquisition. So you generally want to have a threshold somewhere in the 100 to 150 Hounsfield unit range. Whenever the contrast within a region of interest hits 50 Hounsfield units, we call that the arrival time. Then we also have an offset. So this is something that we can specify in there. And this offset will say after the arrival time, wait this long for this given protocol before we start our scanning, also called a diagnostic delay. So you can see after we said our arrival time plus our diagnostic delay, then we started our scanning. So our scan window is right here. And because we'd like to be imaging right when the contrast is at its highest, ideally, we're approximately in this scenario where the start time is actually the peak time minus half of the time of the scan. So when you're setting up your protocols, you're going to want to set up the protocols ahead of time to include an appropriate diagnostic delay, especially on scanners that are very fast in imaging. We really need to make sure this diagnostic delay is set appropriately so we don't outrun the contrast. If we set a very short diagnostic delay, we could end up imaging down here where the contrast hasn't really yet hit its peak. And if we're using the tracking technique, you can see that we're going to essentially set that threshold. And then on the fly, this T arrival time is going to be computed by the scanner. So the steps to do that, actually, we'll take a scout or a topogram, and then we'll say, what plane do we want to image at? To do the repeated imaging, to wait and see where is the contrast. So we'll draw that plane there, and then we'll take an image, and from that non-contrast image, we'll then put some regions of interest. We'll then track those regions of interest over time. And you can see now there's significantly more contrast coming in here. And as those regions of interest are filling up with contrast, you'll see the values going up as a function of time here until they hit the threshold value that was set. In this case, it was 50 Hounsfield units. So once that change in Hounsfield unit is greater than the threshold that's set, that's when the scan is going to leave the monitoring phase and go into the diagnostic imaging phase. So that's when we hurry up and wait. So then there's that diagnostic delay that's set in after the threshold's reached. The diagnostic delay counter then starts counting down. Then we get to watch the actual scanning. So this is actually very quick on modern scanners, where the helical scan takes place, the table moves, you get to see images coming up very quickly. We're going to take a look at those real-time images and make sure that the contrast is on board, and make sure that we actually have relatively good contrast opacification before sending the patient home. So what is that going to look like in terms of the different parts of the body? Like we talked about, we're doing our contrast injection into the venous system. So the pulmonary artery is going to get opacified relatively early in that phase. And if we want to do imaging of the pulmonaries, we would actually want to be somewhere around here. And this region right around here, we'll then put our scan window right in that region. Then you can think about after the blood passes through the lungs, and then goes through the heart, then it's going to be in the aorta, and then we'll be ready to do imaging of the aorta, things coming right off of the aorta. So that would be what the contrast would look like in the aorta, and when we would want to do our imaging of the aorta. Next would be your peripheral runoffs. So the peripheral runoff is actually going to have a slower decline here, and is actually going to be a longer scan because of the length of the scanning that has to be accomplished. And then after that, you could look at the liver. You can see this is what the liver curve looks like. Again, it's a little bit flatter as we're using a little bit more of a slow injection here. Then the actual factors can be separated into a few categories: the patient-specific factors related to the contrast media, and factors related to the CT scanner. We're going to go through those one by one. So first off, the patient-specific factors. I'm going to have several plots, which is from this great paper from K-Tai Bay. This is, I think, the most detailed analysis which has been done in this field, and it actually presents a pharmacokinetic modeling. So if you think about how each of those chambers are connected, how large they are, and what's the resistance for the fluids going through there, you can make a pharmacokinetic model, and then we can make plots of the different areas. So the aorta and the liver are common ones that we're going to be looking at. First thing is the patient size. So how does the patient size actually matter here? What matters is the fact that the blood has to get pumped throughout the cardiovascular system, and the volume of blood that's there is actually related to how large the patient is. So the weight is actually a relatively good surrogate for how much blood is on board. Ideally, you would do something like the lean mass, because if you have a lot of extra fat around your body, it's actually not going to be changing how much blood you have that dramatically. But in general, don't let the perfect be the enemy of the good. Using the body mass or the body weight, you can see that we can actually get relatively linear relationship with the contrast enhancement. So if you're a smaller patient and you get the same amount of contrast, this is a 50 kilogram patient, and this is a 125 kilogram patient. So the smaller patient with the same amount of contrast is going to have significantly more enhancement. You can see that in both the aorta and you can see that in the liver. The cardiac output is as your heart pumps. That is a measure of how much blood is actually coming out as your heart pumps. If you have what he calls a baseline cardiac output, that's shown here in black. And then if you actually think about having a reduced cardiac output, you can see with that reduced cardiac output, that's actually going to lead to a delay in the time for the contrast to get to the liver or to the aorta. It's actually also going to lead to a higher magnitude in the aorta, but relatively similar magnitude for the contrast level by the time it gets to the liver. So now we've hit the patient factors and that cardiac output factor. Because there is a significant delay that can happen, that's why we do that contrast tracking to see when the contrast arrives. So changes that have to do with cardiac output can be modeled to the first order by actually doing those measurements of the arrival time on the scan. The next is the contrast media factors. So the contrast density is the most straightforward one. If you have a higher density of contrast, it's going to stop more X-rays, and it's just that simple. So if all else being equal, it's just linearly related. As you have more dense contrast, it's going to stop more X-rays. You will get more contrast enhancement. This is true in both the aorta and the liver. Then the contrast rate. So we talked before about a fast injection and a slow injection. Contrast rate is showing just that. If you do a fast injection, it's going to be that short injection that we talked about at the very beginning as the sample. So that's shown here. So a fast flow rate will give us something that looks more like that short injection in the aorta. And a slow flow rate will give us something that looked like that long injection that we talked about in our simplified model. So that's how we can understand both the fast flow rate, what it's going to look like in the aorta, and then a slower flow rate, what it's going to look like in the aorta. By the time it gets to the liver, it's had a little bit more time to disperse. So you can see that they're more similar, but you do still see some of that effect. Keeping everything else equal, so if we keep our flow rate the same, our contrast volume changing, all that means is we're going to inject for longer. Same flow rate, and we end up injecting for longer. So if we end up injecting for longer, we're actually going to end up stretching out our curve, and we're actually going to make our curve higher because we're injecting longer. There's going to be more contrast injected, so the curve is going to have a higher magnitude for the contrast enhancement as we end up using a larger volume of contrast. This is, again, the same in the liver, but is not as dramatic in the liver. Then following our contrast, we actually want to push some saline through. And the reasons we want to do this is, number one, is to keep a relatively tighter bolus so that we're pushing forward pressure behind that contrast so that bolus is relatively tighter for the actual contrast itself so that we can make good use of all the contrast that we've injected. This can also help reduce the streaking that we showed earlier in the superior vena cava, because you can actually have mixing there to actually reduce the contrast levels at the superior vena cava. A little extra hydration never hurt anything also, so that's nice about the saline. And then you also get a built-in cleaning of the tubes so that you don't have a highly viscous material of that iodine that's been sitting in the tubes last. All right, so we've done the patient factors, the contrast media factors, now the CT scanner. We talked in a lot of videos before about the fact that the CT number actually changes as a function of how. So we have special video just on that purpose. And you can see that here. In general, if you have a higher concentration of iodine, that's the x-axis here, you're going to have a higher contrast enhancement. But it's going to be even greater for a given lower kVp. So if you go from 120 kVp to 100 kVp, you're going to get about a 25% increase in contrast. And then you'll get an increase again if you go from 100 kVp to 80 kVp. Here's some example images that show that. You can see the 120 kVp on the left here, and then the 100 kVp on the right. The contrast is greater in the case of the 100 kVp because of this fact, because of the photoelectric effect and how it really increases for the lower energies. So low kV imaging, obviously the number one reason we want to do it is for that contrast enhancement, but we do have to be cognizant that we get that contrast enhancement, but there's no free lunch. You do have a higher noise and you also have reduced penetration. So you need to think about that when you're setting up your protocols. You're going to need significantly more MA in order to get enough photons through the body. This is really possible now with modern X-ray tubes, wherein a lot of these X-ray tubes can get well over 1,000 milliamps for the lower kVps, making these actually routinely clinically possible. The different phases, you can see here a non-contrast and early arterial and a late arterial image. And another example here, again, early arterial, late arterial, and portovenous phase. And you can see there's truly different diagnostic information if you look at a region in the parenchyma. For the example of the liver, we have our standard 3 phases. Again, early, late arterial, and portovenous. And we have a nephrogenic phase, which we would want to wait significantly longer, say at least 80 seconds after the contrast arrives. And then not necessarily for imaging, but we also have the excretory phase where the contrast is actually going to leave our body within 5 to 10 minutes after the scan. So now you know all about contrast dynamics, but the contrast agents themselves, namely the iodinated contrast agents that we're talking about here, we have a detailed video where we go over contrast agents, everything you need to know about that. Check out that video coming up next.